2, 1. We are live now.
Can you see my slides?
Yes, sir, we can see.
Okay, we'll talk today. I think we have almost completed trauma. Some of the other things which we'll be talking today. Today, Dr. D Tanna is already there. He'll be talking about the compound fractures. I'll introduce him later. We talk about the orthopedic beyond trauma, joint and spine. I should take through commonly treated entities not responding to conservative treatment where surgery can help. Calcification, AVN, coccydynia, retrocalcanean spur, tibialis posticus, carpometacarpal and thoracic outlet. Today, I think I'll be talking about only this. Now, this calcification, supraspinatus is the commonest. We see this again and again. It's a disappearance of already established calcification which gives inflammatory reaction while it is being absorbed. It is not that the new bone is forming and that is the one which is giving pain. This is what is believed. It is a myth that is the new calcification occurring at the site which gives pain. Since it is too painful, it needs symptomatic relief. Like any acute inflammation, oral and or local cortisone gives a dramatic relief and the patient thanks the surgeon. Now, these are some of those odd things which you can see. All what you need is most tender spot. Here was the calcification. The most tender spot, you find it out. And once the patient says you inject Xylocade with depomedrol, and you will get a very good instantaneous relief. And I continue with the cortisones orally for about 3 to 4 days. And by that time, the patient is fully cured. It is the disappearance already established, as I mentioned. Otherwise, also the calcification would have become symptom-free in due course once it is absorbed. But it's severely painful, so it needs a treatment. Such calcification can occur not in supraspinatus, but many other places. These are so many places which I have encountered, I'll tell you here. This is lateral pelagrinis, it is on the lateral side. And in 3 months' time, you can see it has already become less. And in 5 months' time, almost disappeared. Now here it is onto this. You can see here. And in the due course of time, it just goes away. This is the one which is seen quite often. And it is just doesn't go away. This is their calcification, but this is not an acute calcification which goes away. This is a different type. While here you can see it is in the finger. This is an acute calcification. All what you need is the oral cortisones or anti-inflammatory, it goes away. This is in the wrist. And now, unless you see the X-ray properly, you will really miss this out. You can see here, this is on day 1, and this goes away in 1 week time, it has become less. Or you can see here, it's becoming less. You can see here, this is bigger one, this goes lower down. This is at the NP joint, and it goes down dramatically. 1 month it gets reduced, and in 7 days it is reduced. And it goes on almost disappearing if you take the X-rays. Now you can see here, there was a small calcification here. At that time, I wasn't very clear what it is. This is what is seen very clearly. I operated on a misdiagnosis and cured her. And it is like a toothpaste-like material which comes out of that. And a big fat fizz, I had it. If I had waited also, she would have become okay. So I feel I operated wrongly. She was very grateful because as soon as you operate, the pain goes away. The same thing would have happened if I had injected cortisones or if I had given even the oral cortisones with analgesics. In about 4 to 6 hours time, the pain would have gone away. Now here, all these are the ones which you can see. You can see small calcifications occurring at these odd places here. Now, all these are the calcifications which occur, you will see it. Now, this is the calcification. Again, in few days' time, it is reduced. This is again a calcification, it will reduce. You can see this is the calcification. Again, it is reduced in few days' time. So, soft tissue calcification, it can happen anywhere. Acute, no trauma, with severe pain on the site, involved with the X-ray changes. It appears like an acute pain like abscess without any fever, without a severe, with a severe local tenderness. The appearance is there is nothing just now. And all of a sudden, severe pain comes in. I think it is the main thing. And when you try to press, it is severely painful. And almost to you, once you've seen it once, twice, thrice, you know this is acute calcification. Sometimes the X-ray of a poor quality will not be able to really show that. So you take an X-ray of a good quality and magnify, you'll be able to see this calcification most of the time. Diagnose it at the other unusual places. Otherwise, you will make a wrong money like me. Acute onset with severe local tenderness is the key to diagnosis. Now we come to AVN. This is a very, very difficult and very odd question today. AVN core decompression in grade 1, 2 is the one which has been recommended. Core decompression relieves the intraosseous pressure which is there and is caused by a venous congestion, thereby improving the vascularity and slowing the progress of the disease. This is what it does. If it is a minor AVN, you do the core decompression. Because of this congestion, this goes on increasing the ischemia. And then this area goes on becoming bigger and bigger. That's the reason it collapsed. If you do the core decompression, it becomes restricted and then it becomes all right. Today, quite a lot of things have been done about it. Some people do a core decompression and fibula graft. Some people do a live fibula. Today, what is the newer thing which has come up is to do the stem cells. What they do is they go there, clean it out, make a bigger passage with the DHS reamer, scoop it out, and push in the stem cells. It has been claimed that the stem cells gives a better relief. Still, it is to be proved. The only thing which is proved is that core decompression probably is the one which works. It is a simple one. Now, if you stem cells, it itself cost, you take it out the bone marrow, you give it for a cell multiplication in a laboratory. In Bombay, it is costing 1.5 lakhs for one side, and it comes after 1 month. So basically, you lose that 1 month's time where probably the AVN can increase. So I think at the moment it is in a gray zone, or some people do it is they aspirate the bone marrow 2, 3, 4 places, 5 places, concentrate it, and it has the stem cells which is they push it there. So this is the one which is supposed to give rise to a neovascularization and the new bone formation, and it helps the avoidance of the collapse. But if once the head has collapsed already, then there is no point in doing any of these procedures. So what I do is, does all AVN collapse? Natural history is very varied. Many central lesions in non-weight bearing areas are not under pressure. Now, if it is here or if it is here, then it do not collapse. The one which is there, it is in the weight bearing area, superior anteriorly. These are the ones which are more likely to collapse. So even some people say that core decompression only works in these cases because in any case it's not going to collapse. So I think it is a very varied situation. Core decompression also there is no uniformity. Stem cells also there is not enough evidence at the moment, but still that is a new thing which people are trying it out. The smaller lesions may not collapse as nearby normal bone shares the weight. This is the logic of coring. That if it is a lesion like this, which is small, you do the core decompression. If no further area gets necrosis, then it may just revive without any collapse which is occurring. The current thought process, superior lateral lesions are most vulnerable, must have a coring when they are small, or will be hopefully not allow other normal nearby bone to undergo necrosis, and hence small area of the superior lateral bone will be too small to collapse and will revascularize and become normal in due time. Still, THR rate is very high in this survey group. And this works mainly into the stage 0. That is when I'm talking about you do the MRI. Painful side is the left side. But on the right side, you also see some changes of AVN. This is totally asymptomatic. These are the ones, if you do the coding operation, the results are very good. On the affected side, stage 1 and stage 2, where the head has not yet collapsed, then also the results are better. But otherwise, it is unpredictable. What I do is I do 3 Ds, one small incision, I put in a Steinman pin, and I put the 3 or 4 holes through the Stillman pin in AP and lateral area. I first go here and I see in the AP and see the lateral area. If it is going in the position, you go ahead. From the same thing, you go there. The thing is, do not go lower down and try to make it, because then there is a possibility of a fracture occurring here. This is the 3 or 4 Stillman pins, so that I don't have to put a guide wire and a reamer and take it out and all. The Stillman pin does the job, and that is what I do it here. You can see these are the ones where it has worked. The head is preserved after this 4-day compression which is there. And this is the one you put a small in a sleeve right up to the bone. Once you are on the bone, now you go to the and see that you are and put in these 3 or 4 bigger. This is the one I tried it out at some stage. When the crescent sign is developed, it is going to collapse and get a poor hip. The light bulb technique which has been described by Rosenberg. Cortical window is lifted from the junction. So anteriorly you we are talking about the dislocation of the hip joint, which will the thing.
Dr. Vaibhav, kindly mute yourself.
Now here it is the one which I did it. I made it here, and in this, see the whole cement. This is the 3 months. This is the one which.
Sir, can you mute others, sir?
Sorry.
The noise is coming. So can you mute others?
Do I have that? Please give me the right to mute everybody, please. OrthoTV girl, who is there? Poonam? Poonam? Now this is what is being done. This is after quite some time. This is, I remember I had taken it after 3 years. Now same thing can be filled up with the bone cement, which will not need any reverse solarization. And that time gap for obtaining strength in that most vulnerable superior lateral zone is avoided. So here it is. You open up the hip joint from here, pour it down, seeing at the MRI, which is the area, and then put in a cement. And this is the one where even if it is collapsed, it has been there, you can punch it out and you can probably open it out. Now this is the experimental things not being done. I did few cases and afterwards I have stopped. Though it has been there in the literature, but there is no recent literature on this. And then the reason I think I felt in today's days of really the litigation, I didn't want to do a surgery which is going to be, but all these 6 or 7 which I have done, I think they have done reasonably well. They are not normal, but they have been carrying on for 8-10 years. Up till now, none of them have had a THR for last 8-10 years. Now here you can see this is the other case. This is 1 year. Here is the incision. You can see it here, the good range of movement, can squat down and everything. This is 2 years. You can see the good range of movement and everything. So this is what is the core decompression and the current status. And I think I also would like to say, Nina, if you are there, please share with me. The core decompression which we see these days after the COVID, I feel somehow my observation is it is not as cynic, it is not as sinister as the one which we have seen it in past of AVN. I feel that so many times we advise them a core decompression, and then they at times come after 6 months and they say it's perfectly all right. The impression is that it is not all of them are not taken cortisones. Some of them who are intelligent say, no, we had a COVID, we were at home, done nothing, and we have not taken any cortisones, I had no chest problem, and still after 2 years they get a AVN. And we see those changes on both sides and all. Now the other observation is if the neck is also affected, and if it has a reactionary area there, then it is not that sinister. But if it is only the head is affected, then at times it is sinister. But honestly, in COVID avian, I have not been able to really predict whether this will become all right or no, whether core decompressor is mandatory or no. Any observations? Dina? Who is there? Dina? Dr. Dina, you are there? Dr. Dindayal? Asim, you are there?
Yeah,
You have any observations on to this COVID avian?
COVID avian is many patients they are getting without steroid, as you said, and I feel that more patients are ending up in THR rather than previously seen early avians. The lesions they are larger, affecting more often the weight-bearing zone, as you rightly pointed out, and are bilateral without getting any steroids, home treated.
Dina, are you there? Okay.
Sir, I have noted, Dr. Wankade here.
All right. Yes, yes, no, yes.
Post-COVID patients, avian, they get very early deterioration. Whenever they reach to you, the patients, they are already collapsed with the head and there are arthritic changes. So that's what I have noted.
These are different observations of different people.
Yeah.
Anyway, we go ahead. Coccydynia, I talk about. Pain on sitting on the hard surface. No pain on standing or sleep. Local steroid is not helpful and it may give a local infection. I have never done the local steroid there. If at all some people do it, if the coccyx is painful, they do the manipulation, putting in a PR, and they really move the coccyx which is angulated, and they feel at times it gives relief. But still it is debatable. Recalcitrant cases do a need excision of the coccyx. Never do the excision before 1 year, because I would say the 95% of them will resolve automatically without doing anything. The results are better of surgery only after if it is traumatic. But non-traumatic ones, I never try to do the surgery. And this is the one I feel that probably there is quite a lot of element of psychosis which is there. So non-traumatic coccydynia, I generally never try to operate. Now here you can see the coccyx, which gets in a different shape. They settle down most of the time, very rarely need surgery. If it does not settle in about 1 year time, excision of a loose piece of coccyx, we consider. Now you can see here, this is the injury, this is the fracture, this is where it is. Now you can see here, this is the one which I have done the surgery. This was the coccyx, so I have removed this last mobile piece of coccyx, and from here you can see all this part I have removed. This is the typical coccyx you can see. This is the part of the coccyx which is there, and with surgeries, you can see it here all the time. I'll show you the video of the surgery also. Coccydynia surgery is not commonly done. Loose coccygeal piece be excised. I have done about 30 cases through all these years with very satisfactory results. The result is rewarding. Whether they would become all right without surgery over a time is anybody's guess. But I have never operated them before 1 year. Now here is the video. You can see this coccyx. Knee chest position. It is the vascular area, so I give a local infiltration after preparations and everything.
All the way bone. Once you go to the bone, you can start infiltrating. Because if you deviate, you'll be infiltrating the rectum.
Be in the center. And then you are right onto the bone. Go on to the bone. Once you cut, you still be onto the bone.
Yes, sir. Next
You
time.
can see the bone.
Fine.
You can
Next
see the
time.
movement. You can see the movement. This is the one which is very amenable.
Very good.
How I go, I'll tell you. In the surgery, In books, Campbell, there is no mention of a surgery of the coccyx. Earlier it was there, which I remember where earlier there was addition of coccyx. They recommended one sterile hand you keep it, the other unsterile hand you do the PR, and from there you fill it and you push the coccyx and cut it. But I have never done that. This is what I do it from the loose area. From the loose area. I try to take it out. Where it is, I use nothing. Try to make it. Separate from the junction where it's removed. The type of tissue is removed. You remain on the bone all the time.
Yeah.
I'm on the bone all the time. As you can see.
You see the joint now? इधर आ जाए पकड़ से फिर से कर है पिक्चर दे रहे नहीं
Just to the bone. As you can see.
I found this is the one which is more easier than go from below.
But this is only theoretical. If you are there flush to the bone, nothing happens.
अभी फोटो निकाल दो
Hemostasis. Do the good hemostasis. Close the wound in layers. And 3 days of induced constipation so that things has a chance to heal up and there is hardly any infection occurs. I think because this is the one which I have done sufficient numbers at the moment and I feel this is the one which works quite all right. Now we come to, if any questions, please stop me anywhere. Huh? And then any questions up till now what we have spoken?
Sir, during a coccyx surgery, chances of getting a rectal injury are there?
If you are very, very careless, then it can happen. But I have, because as I said, if you remain flush to the bone,
Okay.
hardly ever if you can get a chance. Even if you go from the lower down, if you are onto the bone, then it never happens because there is quite a lot of area which is there between the soft tissues and the rectum down below.
Okay.
Now this
Sir,
yes.
for this soft tissue calcification, you propose that we give local steroid at the most tender site.
It will give you a very good relief immediately.
Okay, so then is there any contraindication to not give it? And chances of ligament or tendon tear in such cases?
Exactly. Just a minute to know what I am talking.
Yes.
When you try to give injection, it is so painful. So when you try to find it out and you put the injection, patient will yell and shout. So to me, I have given up the injection because I become all right by heavy dose of analgesics and the cortisones. I give at least 12 milligrams in a day, or at times even 16 milligrams in a day, 1 or 2 days, and taper it off. Their pain goes away.
Okay.
So I have generally as a do any cortisone, any injection today.
Okay, sir. Okay. Thank you, sir.
Any other questions before we proceed further? Okay, this is the retrocalcanean spur. I am not talking about the calcanean spur which is at the heel. I am here talking about it behind the tendo Achilles. This is the typical retrocalcanean spur. You see this
Sir, your slides are not seen.
Big bump there. This is the typical thing what we're talking about. So conservative.
Sir, your slides are
if
not
the pain
seen.
is severe and it continues. Okay.
Slides are not seen.
I got the message just now. My internet is on. Take over. Tina, can you unmute yourself?
Asim sir,
Good evening, sir.
good evening, sir. So Tanna called me and said I can talk
Yes, sir.
about. I will
His-
take over.
Yeah, his connection is not stable.
Okay.
Yeah.
So I will share my screen, sir.
Yeah. Yes.
Hello, everybody. So this time, probably at the fag end of this fellowship, I am coming in. So, so Professor Tanna, you all know that selflessly he is teaching every one of you, and we have all learned a lot from Professor Tanna, and I'm happy to be part of this virtual trauma fellowship. So to begin with, am I audible, sir?
Audible, sir.
Yes,
Sir,
you are audible.
very clear.
Okay.
Very
okay,
clear.
Okay. So I have been given the opportunity to talk to you about the open practice. This open practice is routinely we are doing it in large numbers over here. And then I being the part of the great team here and I get the opportunity to work on these open injuries. So this is the number we have done, like type 3 injuries. You can see that almost around 550 patients we have done in this time. So this is the statistics of 2021. So this year we are almost limping back to normalcy. And we have also contributed to the open injury literature a lot. Large number of papers are all written. So it's all in the literature, you can go through it. And the full credit must go to these two brothers who made that open injuries as an orthoplastic approach. So that has been made possible. And then we follow all the principles laid out as an orthoplastic approach here. So to begin with, I want to start off with some of the basics, like you all know about what's open injury, but I don't want to dwell on those. But in all these open injuries, what we need to do is to achieve bone union, prevent infection, and restore function. These are the three ways that you need to look at all open practice. If you look at the various stages, you see like they undergo an inflammatory phase and the reparative phase and the remodeling phase. In an inflammatory phase, most important is the hematoma, that is very important. Whereas in the reparative phase, it is almost like you need to have an establishment of a closed environment and the stability. When these two are there, then the reparative process will take place. And of course, remodeling is after the healing process. So if you take the hematoma stage, so what is important is that in this hematoma, you have all the signaling molecules, the platelets that are responsible for getting into all the chemotactic factors and things like that. This is a very important factor. Whereas in open fracture, what happens? This completely goes away. So there is no hematoma. So immediately you know that the union, whatever is required for a union is lost. So that is one aspect. And the next one is, like as I said, in the reparative phase, you need to establish a closed environment. If you don't establish a closed environment, again the neovascularization won't take place. And then if it is not closed, again other aspects like desiccation and drying of the bones also take place, and again leads to a non-union scenario and infection scenario. So that's why you must establish a closed environment quickly, bring in a blood supply, new angiogenesis will take place. And at this stage, you also have to make sure for newborn formation to take place, callus to establish, there must be a stability part of it you have to give. And once you give a stable fixation in that situation, then it will go on to the next stage, and then it will end up having a good healing. The other aspect in open fractures is also like contamination. You all know that the open fractures, moment when there is a injury, when the soft tissue strips open, there is a vacuum into that effect. So the suction effect will be there, and a lot of mud particles get into various planes of these open injuries. So we need to identify it and then completely remove all the contamination. Then it will end up having a good surgical wound. So there is prevention of infection becomes a very important factor. And also like the contamination is, once you do the debridement, the virulence of the organism that is there also makes the difference. Suppose if it is a less virulent organism, yes, you might escape. Whereas if it is highly virulent organism, then it will be a problem. But you also know that all these organisms that come in open fractures is not because of the injury by itself, but many times from the hospital environment. So you need to be very careful. So moment patient walks in, so you need to immediately cover it so that there is no contamination in the hospital that takes place. And also there are various factors that play into the picture, like local and general factors. And all of them put together, the pathophysiology that works with this results in a good way of dealing with these open injuries is that when there is a tissue trauma, like you must also give early antibiotic administration and meticulous surgical management with the debridement, and then stabilization is very important. And also like in these instances, see like there is extravasation of tissue, there is a edema that develops into it, and also there is increased interstitial pressure. To circumvent this edema and interstitial pressure, you can also think of a negative pressure management, negative wound suction management that you also look at. So that pulls off fluid and then decompresses the interstitium. So these are various ways by which you look at based on the pathophysiology of these open fractures. These open fractures come in various forms. It can be from the very minimal one to the maximum injury. And then it can be like those which are easily salvageable to barely salvageable. So it also can end up with amputation. So there is always a worry about what are the types of cases that you can salvage and what are the types that you can amputate. And also when it is a part of a polytrauma or a life-threatening situations, then again you need to look at how do you manage these injuries. But you also must understand that it is a disease of hemorrhage. So you have to always manage not only as the other areas of injuries concerned, but as a disease of hemorrhage. So when it is a disease of hemorrhage, then various factors play in, like not only what is the amount of resuscitation that you need to do, how much of blood products that you need to give, and associated transfusion related reactions, everything you need to take into account when it is a hemorrhagic disease as well. The primary management, of course, consists of ATLS protocol, hemorrhage control, and then whatever the life-threatening and limb-threatening conditions you need to sort out, like if it is a limb-threatening compartment syndrome and vascular injuries, you need to look at. But always remember that documentation is extremely important. Photograph them, because the memory is short for the patients and the attenders. Tomorrow, when the outcome is there, you need to show them these pictures, the early pictures, then they will all agree. But if you don't photograph it and then finally end up having some sort of a problem with these open injuries, then they will always question that they spent more and then they have not a good result. So you have to document everything and keep it. And as I already said, sterile dressing immediately when they walk in is very important so that hospital contamination doesn't take place. And then the limb splintage, antibiotics, tetanus toxoid, analgesics, all of them you will give and then later send them for X-ray. But when you are having a open injuries, you all know that they are having a high velocity injuries. They will also have a head injuries like thoracic injuries and then other systemic injuries that you need to sort it out. And then it is all directly dependent. These injuries are directly dependent on mortality and morbidity associated with open injuries. So you have to sort them out. And pelvis fracture, if it is associated, again, it's a cause of concern and you need to manage them appropriately and then get it right. So of course, always a question comes, what type of a saline solution you must use, isotonic saline or ringer like so crystalloids or whatever it is. But thing is, isotonic saline and ringer lactate both can be used. And then the fluid management must be like almost like earlier times they used to say 2 liters of fluid you give immediately, but it's not the case. It is modified as the ATLS protocol has modified it to 1 liter of fluid. But the blood products you must give because it is a hemorrhagic disease. Whatever is lost, that must be replaced. That is the concept that has to come in. So, and then the blood products that you use always is like 1:1:1 as in polytrauma. So always when there is a blood loss, you give it like a packed cells and fresh frozen plasma and platelets in a 1:1:1 ratio. And if you ask what is the best fluid, then of course the whole blood, if you have fresh whole blood, if you have, that will be the best. And also you can replace it at the rate at which it is lost. You can also replace at the same rate that is lost. Then it will balance would come through. And some of them would use a tranexamic acid in the beginning or during the anesthesia time so that you can reduce your blood loss. So as I already said, documentation is extremely important. And then this documentation is not only for medical legal purpose, but also like for patients, you can continuously tell about it. And examine them when completely exposed, because if you don't expose it, often you try to, you will miss it up. So you'll have to make sure that you completely expose it. If there is a gross deformity of any of the limbs, you just, as regular protocols, you straighten it and then check for your vasculature, everything that is there. Sometimes the pulse won't be felt when it is in the crooked form. Once you straighten it, it will be felt. And then any of the bony fragments that are sharp and then projecting out or pressing on some of the other structures, you need to see and then get the limb in a good traction. Then sometimes it gets sorted out. And always have a neurological assessment. Sometimes you won't assess the neurological, then it becomes a problem. And later on, if the post-operatively, if you go and tell them that there is a neurological injury, they may not accept it. Again, that is the issue. So document it very well. So neurologicals and then the vascular involvement, compartment syndrome evaluation is extremely important in an open injuries as well. And then when there is a doubtful pulse, first is the correct deformity and then put traction, do a pulse oximetry and then Doppler examination. If nothing works, then you can also think about angiography depending upon, say for example, there is an open wound in the proximal tibia. There may be a wound on the anterior aspect, but the bone fragment would have gone behind and then pressed on the popliteal artery. And then if you don't get it, the best is to get an angiography so that you will mark out where exactly is the popliteal artery injury, and then you can tackle it as and when that is required. As I said, the open injuries are a hemorrhagic disease. So you will have to make sure that the blood loss is minimized. Immediately apply a direct pressure. And then if you are in the hospital, if you are able to take the patient very quickly to the theater, you can also apply a tourniquet in the casualty. Suppose if you are not going to take the patient immediately to the immediately to the preoperative room and then start operating, if there is a time delay, better not to put a tourniquet. Suppose if you forget, if they go for any of the investigation, then again due to tourniquet, you will lose the limb. So you have to be very careful. You can apply a direct pressure to stop the bleeding. So, but in those instances, you should not panic. See, like Here you can see that lot of artery clips have been put in and then sent. But in this patient, when they are trying to put it, they also put it to the neighboring structures. And then when they are trying to catch the vessels, they will almost always catch the nerves as well. So you'll have to be careful. So do not panic. Do not put lot of clamps like this. So you must make sure that you just apply a direct pressure and send it across, or you can manage it in your theater quickly. As I already said, this is very extremely important. Motor power evaluation is difficult, whereas touch and pinprick testing is possible in autonomous zone. So you have to check that. And also it is very important for your compartment syndrome management as well. So you have to make sure that you evaluate all of them. Antibiotics are always therapeutic. They are not prophylactic, especially in open injuries. You must remember that they are therapeutic, not prophylactic. And you institute is as early as possible. And then, of course, depending upon your hospital protocol, you can choose. What we use is the cephalosporins and then aminoglycosides if needed. We also add aminoglycosides, but cephalosporin remains the choice. So here you can see that we always give it. So cephalosporin 1.5 gram 8 hourly until first debridement. At first debridement, cephalosporins and then some gentamicin we add in case if there is a soft tissue management becomes delayed. So otherwise, there is no problem. If it is a farmyard injuries, metronidazole can be added. So this is how we use. And all of them are given as a short course. We don't give it continuously. Like, so we give a 3 doses, or sometimes we end it up by second day, we finish up the antibiotics. So not beyond that. In case some of the times when the soft tissue, the cover has not been done, then the antibiotic goes on to the second day. Otherwise, not. So imaging, you can see the trauma series. All of them are important. You have to make sure that I don't have to tell all this to you because you all know about what you have to do in all this. So every one of these you must check: pelvis, chest, spine, all of them. You take like a polytrauma in a scenario like whatever you want to do, you have to completely do it up. And then whenever there is a complexity involving the joint injury, sometimes we also take a CT scan. Suppose if there is a joint involvement where you want to initially get all the articular fragments ready during the debridement itself, it is better to have a CT imaging also if it can be done quickly. So for the success of your open injury management, debridement remains the key to success. So the debridement and debridement is the only method that you will have to look at. And debridement is an active surgical procedure. So it is not like I put lot of saline and then it is not a debridement. So you must remember that it is an active surgical procedure where you remove dead or avascular tissue and foreign material. And wound washing is not a debridement. So, but at the end of it, I always tell that knife is the only solution for you. And then at the end of it, you make sure that there is any non-viable tissues. You must leave only viable vascular tissue without any contaminants. Then your debridement becomes complete. There are various ways by which you can think of doing a debridement, but in our hospital, we always use a tourniquet and a magnification. So the plastic surgeons is the one who do the debridement for us. So, and always it is done under tourniquet and magnum. With tourniquet, see, like you take every opportunity. Suppose if there is a big degloving like this, you put a tourniquet on this area itself, but whatever the area that is exposed now, you debride it distally, so that when you are debriding it, you will see clearly. You don't have to mop and then go back and then mop, go back and then mop, and then you will also keep contaminating whatever you debrided. So best is you debride with tourniquet and then nicely first make sure that when you are doing like this, the hypotension would not happen because there won't be any blood loss at this stage. Then once it is done, release the tourniquet, achieve hemostasis, and then go back and do the other areas. That becomes a limited area where you need to do a debridement without tourniquet, and then the blood loss will be less at that stage. And also there is always a question that would you do debridement within 6 hours? Because earlier days it was considered within 6 hours you have to do the debridement. But nowadays, the paper, lot of papers have come out and said that it is not absolutely necessary to do within 6 hours. But whatever the stage you do, at the end of the debridement, you must get a good surgical clean wound. So when you get a surgically clean wound without any contamination at any stage, then it becomes a good area for you to go ahead and do a next method of management. Once it is completely debrided, at that stage, you can use any of the irrigation that you want to use. Some of these you can use autoclaved water also you can use. These are the things that we also use here. And then see like all these bottles that are there, we keep our water and then autoclave it and keep. And nowadays we don't get these bottles. Earlier we used to get these bottles, but nowadays we are not getting it. But whatever we had it before that, we are trying to use it. But if you don't get it, then you have to use just a saline bottles you can take and then start using it and then clean it at the end. So this is in the webcast that I did in, I demonstrated an anatomical specimen at Mutens, Switzerland. So this is the one that you can see that what you need to do is a very thin layer of skin, you can take it off at the edge. So when you are taking it like this, and then you can lift the skin slowly. Don't try to cut off all the skin, because if you see any of these infections and things like that, is all underneath, not on the skin. So it is only a necrosis of the skin that matters. So you just trim the edges, and then once you trim it, and then whatever underlying the skin that is loose and damaged, then you remove it off. Once that is removed, then if there are two wounds in between nearby, you see appropriately the best way to connect these two. And then once it is connected, then you can see you can elevate it nicely, and then underneath you can see better. And once it is seen, then you can, whatever that layer of tissue that is not connected to the skin, you remove it off. And then once you remove it, you must always get into the area where there is a fracture. The fracture ends must be seen. But here it is anatomical specimen that is broken. But whereas in a normal patient, always the fracture ends would be seen outside. So you can see that once it is done, then all the small pieces that are bones that are not having any soft tissue attachment, you must completely remove it off. So you do the tuck test, and once you do the tuck test, and then if they are very easy to remove it, you can remove it off. But if soft tissue attachment is there, you can retain it. The muscle that you are seeing it is, suppose you try to pinch it and see. Once you pinch it, and if it stays in that position, so if it is getting molded, that means they are not viable. So you need to remove it off. And also, if the color of the skin also matters. So usually it is bright pink in color, whereas sometimes if it is very dark, if it is reddish in color, or if it is, you can see some of the times it is a confused zones. And then if you are putting a cautery, it won't have any stimulation. So all those things, if it is there, then you need to remove it. Sometimes when you are pinching it, it becomes like a doughy consistency. Again, then you need to remove it. So if there is no bleeding, no contractility, all those aspects that you need to look at, and then you need to cut it, because muscle forms a great nidus for your infection. So be generous in removing whatever that is not good on the muscle, and then whatever that is not having any soft tissue attachment, you just remove it off, then it will be good enough. And also you must know that you need only, see, like if you read in poliomyelitis, what do they say? If there is a 60% loss of motor neuron cells, that is the motor neuron functions, then only there will be a weakness of the muscles. On the same concept, you can be very generous in removing these muscles. Don't leave any of the necrotic muscles inside. And once that is done, then next area is also like you can see that here you are debriding it. So once you debride it, and then the same methods that you do, at the end of the debridement, what is important is once you have seen that all the contamination is completely removed, and what you are leaving behind is only the viable tissues, then the reduction becomes important. Because if you can achieve a good reduction, sometimes the bone characteristics may not allow you to have a good reduction. Suppose if this is a configuration you have, so it is like a sawtooth, and then if it can get locked into the proximal and distal portion very well, The stability that is achieved by the fracture itself is become a very good for you to have a good fixation. Suppose if you depend only on your external fixator or external fixators, then stability may not be good enough. But if you can achieve a good interdigitation of these fractures and then have a good reduction and then put an external fixator, stability will be even better. So once it is done, then you need to analyze how the skin is. If you can stitch it, if there is no tension, then you can again go ahead and do a primary closure as well. So these are the ways by which you need to look at all those. So this is the anatomical specimen dissections that we did in Switzerland at that time, and then it is also available in the archives of AO archives. You can also go through that. Once this debrainment is done, then your classification comes into vogue. So based on this size, you know that Gustello classification has been done, and then see like they have all these. Now the Gustello classification is based on not only the wound size, but also soft tissue damage, contamination, fracture comminution, periosteal stripping, skin coverage, everything they have taken into account of late, and then they have formed the classification. But still, if you read a lot of articles, there are various ways by which intra-observer and inter-observer error rates are there. Because there is intra-observer and inter-observer error rate, and we also, in our experience, we found out that that was not very great in getting a good outcome management part of it. So we revised one of our classification, and it is the Ganga Hospital classification. Now it also has got published in all the textbooks as well. And also now it is a postgraduate curriculum. So people have started asking questions on it. I'm sure that all of you would have known about it. And I don't want to dwell too much on this. So it is an integument that you look in. The various ways by which it is, the severity at which it has increasing levels, and then the fracture also the increasing grades, and then the functional tissue, the way it is all torn and then it is all damaged based on that. And then as a whole, the patient must be taken into account with all these comorbidities. In principle, what we do is all this integument and then the skeleton and then the functional tissue and then the patient as a whole, we take it into in account. And then we are giving these marks based on the skill levels required. For example, if it is a transverse fracture, you would require a less skill rather than having a big bone loss. Similarly, if there is a small lacerated wound, will require a skill that is less compared to a big wound where there is a complete skin loss. So like that, based on the skill levels that are required, we are giving a score onto each of these. And then that is incremental score for all of them is given. And then based on that, you do a collective scores for at the end of it to get a total score. And then once you get the total score, in addition to these comorbidities, then we give a total value. So if it is up to 14, then you are able to salvage. If it is 17 and above, you have to amputate. But if there is between 14 and 17, see like 15 and 16, then it's a gray zone where it is infrastructure, cost provider, skill of the team, and then of course patient factors, everything you have to take into account and then tell them about whether you are going to amputate or not. So all these we have made it as a salvage versus amputation recommendation based on the total score. So here you can see that the patient has got a total score of 15. But unfortunately, in this old man, he also recently had a myocardial infarction. So these type of patients will not tolerate multiple staged procedures. So best is for them is to do an amputation and then make them walk early. So the choice of limb salvage pathway is also that is dependent on, see like generally we all tend to do from resuscitation to skeletal stability, like up to external fixator, all of us will do. But beyond that, like soft tissue cover and definitely bony procedure that is required for each of these patients called the global reconstruction. Sometimes we will do and sometimes may not do. But there must be a general criteria by which you could do. So that's what we have also tried to tell in the Ganga Hospital score by various reconstructive options like fix close, fix reconstruct and close, fix skin graft, fix flap, fix weight and reconstruct. All these methods of philosophy are all coming into the Ganga Hospital score. The skin score always tells you about the suitability of cover, whereas the total score, it is going to tell you about the violence and then you can also decide on the management. So here you can see that the total score is less, 4. So when it is total score is less, that means that it's a low velocity injury. And also skin score is, you can see it is 2. So when this is the combination that you have, you can also think of fix as well as close technique. So you can also, you can see this is the other one. So it's almost the same amount of scoring. And then you can see like here the size of the injury, like what if it's the Gustilo classification, it grades jump. Whereas in scoring, it remains the same because it doesn't vary. The skin score remains the same, though the size has increased, but still the score remains the same and the treatment remains the same. So similarly, if there is something that is required, so here it is a combination of the bone. And then when there is a combination and you do a tuck test and it comes out, then the dead space, you can also manage it with bone grafts. So you can also put back in bone grafts and then do a nailing and then cover it. And then because in this, the score was less, total score was less, and then you can go ahead to do all these. So what we have done is, if the score is total score is 9 and less, then you can do a global reconstruction. Whereas 10 and above, you must think of a staged reconstruction. That's what we always try to do in these patients. Here again, you can see the score is less, but the skin is 4. So here it requires early cover. So we have done on the same day, we can finish it off as soon as we nail it, and then they get a good result. So that is why we said total score of 9 or below, you can do a total reconstruction. So whereas more than that, you always go in for a staged reconstruction. So here it is 9, less than 9, and then you can see that immediately you can do it and then get going. Whereas if it is 11, then you need to stage it. So you take you first initially you put an external fixator, and then you wait and then do the flap. So here you can see that this is a total score of 14. So there is no question of any of these early fixations. You will always have to do a staged reconstruction. And then you can see that when we do a staged reconstruction, sometimes instead of early external fixator and then change over, many times the orthofix itself, we use it as an external fixator as a primary fixation, so that we don't have to do any other further procedure. And then as the time passes by, then all the other reconstructive options you can do and transport and then get it sorted out, docked, and then. So with this, our Ganga Hospital score also has been studied by our Dr. Devadas et al. Group, and then they also found out that whatever the results we said, they're almost, they say that it is applicable to every one of them. So they also published it and then written it about it. And what we say is the success in open injury management is based on answering the question of salvage. And then you also must have the timing of reconstruction correctly done. And then the choice of limb salvage pathway that you need to look at in all these patients. So in essentially what it does is, individual score provides guidelines in treatment, and then the total score helps to decide salvage and prognosticate the outcome. So that's what is very important in this Ganga Hospital score. So it also notifies the complexity involved in this. A skin score of more than 3 always requires a flap. Bone score of 4 and 5 always requires a complex reconstruction. Score of 9 or less, you always can do a global reconstruction. Score of 10 or more, you have to do always a staged reconstruction. As I said, the cultures, the hospital infection is more common than any of the infection that is coming from the environment. So you have to be very careful. So you need to know what is the hospital bug that is there in your hospital, and then your antibiotic must be directed towards that a spectrum of cultures you get. So how much to go on day 1? So there is always a question that is asked, how much you can do on day 1? So it always depends on the patient's personality. If the general condition and local wound condition permit, you can go and do a definitive fixation and cover if possible. If not, staged reconstruction is advisable. Always anesthetic guidance is important. In our hospital, we always tell that anesthesiologist receives it, plastic surgeons debrides it, and we go and fix it. So that is the method by which, because all these injuries, which are major injuries in our hospital, are always received in the ante room of the theater. and then anesthetist is the one who receives it. So once it is, all these are, when resuscitation, everything is set in, the debridement team goes up and then we go and fix it up. The skeletal stabilization that you need to look at is based on the wound and the fracture pattern. And then the external fixator is the workhorse in the management of all these open injuries. And suppose if it is an upper limb injuries, if it is a femur fracture, or if it is a, if you take Gustilo grade 1 and 2 injuries, and that if you want to put Ganga hospital score of less than 9, the majority of the times you can also think of internal fixation. So as I said, external fixators are very versatile, and then they can be applied very swiftly. Suppose if there is a, say there is a vascular injury, you need to be very swift. External fixators comes in handy. Suppose if the patient has come very late, you want to debride it, and then you don't want to take any risk. Definitely, nobody wants to take a risk in internal fixation when patients come very late, and then there is already some sort of colonization has set in. Then you should not think of any internal. External fixation is the only choice. Pediatric practice, again, external fixators is the choice. So you have to think on all those lines. And then the contamination is something that you need to always look at. Contamination is always a suction effect. You need to debride layer by layer and then get it out. And based on the contamination also, you need to decide. Suppose if it is excessively contaminated, you must not be too vigorous to go and operate with the internal fixation. But always remember that if you have done excellent debridement, a plate fixation is an option. Suppose if there is an open articular fractures, periarticular fractures, or in a fracture where there is a minimal periosteal stripping or minimal soft tissue damage. As I already said, upper limb or femur injuries, all these things, you can think of a plate fixation very quickly. So these are the areas where you can think of a plate fixation. And then otherwise, it is very difficult for you to put an external fixator also. So these are the areas where, again, if the debridement has gone extremely well, and then safely you can go ahead and do an internal fixation and then get it sorted out without any problem. And also when you want to put a nails, so the nailing also, some of them would say that earlier days we used to always have a discussion on unreamed versus reamed nail, but nowadays that debate doesn't exist at all, because you don't even get an unreamed nail. Whatever the reamed nail you have, do minimum reaming, but you don't have to think of maximum reaming like a non-union scenarios. But you need to look at minimum reaming and use the thinnest nail that is available for you. Whatever that permits for the patient, you can use it. And also, like, only advantage is that if you when you are doing it, femur fractures, majority of the time you can do a nailing in these open injuries. In the tibia fractures, if you have debrided well, and then in a scenario where you can also think of early flap, you can also think of doing a nailing as a primary approach. So as I said, Ganga hospital score, where your scoring total score is less than 9, you can think of putting it. Gustilo 1 and 2, again, you can think of doing it. So you have to look at this. So here you can see that this is almost like any of you would always think of nailing and then closing it off like this. So I'm sure that a lot of you would do it. And also here again, you can see that here there was after debridement required a cover. If you can cover it immediately at the time of fixation, again you can go ahead and do a primary nailing. And you can see, like, when you are the nailing, you must be very cautious in a scenario where it is a segmental fractures. Segmental fractures, extreme caution must be used when you are doing a nailing, because sometimes when you do a nailing, and if the segment is almost like a non-viable segment, it is completely deglowed skin is there, then it will end up having a necrosis, and then you will have a lot of problems later. So if you are very confident, if the segment is good, it is having a good soft tissue attachment all around, then you can think of a nailing of the immediate cover. So that is all you need to look at in these patients. Suppose if you have used a lot of external fixator in the beginning, always a question comes, when do you change it to nail, or when do you change it to internal fixation? So whenever there is a scenario like that, see here, you have put an external fixator, and then after some time you go back in and then do a internal fixation. Lot of questions would be asked whether when do you change it to internal fixation. Our protocol is that if our Shan's pins did not show any irritation, there was no redness, there is no fluid discharge from the pin tract, then we can as well remove it and nail it on the same day. But however, you must also remember that the safest method that has been written up is to always give a window period, remove the external fixator, at least leave a gap of 2 weeks, and then go ahead to do a nailing. So by far in the literature, whenever the external fixator is removed and then the nailing has been done, they have said that from somewhere around 15 to 20%, there is a chance for infection. So you need to be very, very careful in deciding this when you are changing it to from external fixation to the nailing. And also, like when you are looking at all these, see like this open fracture, and as I said, see this was referred to us after something almost like a symmetrical injury. It was referred, and then what we do is we go ahead and do a debraid again, and then put a limb reconstruction system, mount it, and then it exactly almost like a similar fracture, and then we transport it, and then once it is transported, it gets into docked position, and then once it is docked, and then he is also moving around with these LRS frames. At the end of it, once it unites, then he goes back to normal function. So these are the ways by which you can think of. But what is important is you must be aggressive enough to get a closed environment as early as possible. If that is done, then your bone management becomes easier, because all the work must be based on to prevent infection. How do you prevent infection? Get the cover early. How do you get it united well? Then you need to have a bleeding bone ends at the end. So if you have a bone ends that are very much bleeding, then when whatever the method it is available for you to get it docked and then do it, or if it is bleeding very well and then primary fixation also you are doing, as long as it is a bleeding bone and good closed environment is achieved very early, then there is no problem at all. All of them will have a good outcome. If you ask what are the various soft tissue covers that are available, you can see that various covers are available. Our plastic surgeons can do it. So, and all those methods that are available, your plastic surgeons also will be more willing to do it, provided you call them very early. A lot of the times, if you don't get them involved on day one, so they will also will be hesitant to come when you are calling. So always, we have a lot of plastic surgeons coming into our hospital to get trained. And we have all of them, we have discussed with them, and then we say one of the grows they have is that, see, we get called only very late. We don't get called early. That is what those plastic surgeons keep telling us. So that is one of the best way to do is always you must have a colleague who comes in as soon as your patient comes in, then it will sort out all the problems. So you can also be doing it very early. So rehabilitation remains the key in all these patients. And then beware, like any pre-existing medical problems, you must also evaluate them and then get it sorted out. Promote involvement of members and patient family. Always have a same number of people discussing with you. See, one fine day you discuss with somebody, and then next somebody else, next day somebody, then that it doesn't carry on very well. And then they will also note that whatever the message we give to somebody, when they pass it on to somebody else, it won't be the same meaning. So you'll have to be careful. So whenever you are managing with open injuries, make sure that you speak to the same attender and then same family members that you spoke on the day one. They must be present every time you speak to them next. That is very important. It is also important that we need to know the pre-injury level, that is the function, pre-injury function, because some of the times these patients, when they are having an injury, open injury, maybe they are not actually truly very active. So they will also have some. So you will end up having some of those patients also. So you need to be very careful. So all these, whatever the method of fixation that your treatment that you are getting into it, you also must be tailored to the patient needs, and that's what is very important. In summary, all of them you must have a good initial management. Debridement is the key to success. Appropriate diagnosis, scoring of injury, and then appropriate management. Correct staging and skeletal stabilization will give you a better result. So, Asim sir, if there is any questions in this here, we can take. Otherwise, I will go through some of the examples.
In the chat box, there is hardly any new question.
Okay, sir. Okay. So here you can see this 27-year-old male. So in this, there is a comminution, and this is the wound after debridement. So the majority of us would definitely think in terms of covering it quickly. And then you can see as planned, we also go ahead and then cover it very quickly. And then this is the fixator. But in this case, because the alignment was good, so what I decided was like pin tracks was maintaining well. And patient also financially was not sound enough. So he asked me whether can this be retained. I told him that compared to if every X-ray is showing some amount of healing potential, I would definitely retain it and then go ahead. So this is what I did in this patient. And at the end of it, only with external fixator, it goes on to heal. So that means you also, as I said, you need to tailor it to the patient. That means you discuss with what he wants, and then you go ahead and treat it in the same way that you feel comfortable with what patient also needs. And this is at around 1.5 to 2 years. And then you can see that he gets a good function all, and then he walks well. And here you can see that this is a 21-year-old male, gas cylinder explosion injury, sustained crush injury of left leg, no distal neurovascular deficit, no other injuries. If you look at it, the fracture ends are almost from the proximal to the distal. And you can see the skin is, majority of you would have seen like this. And then when the skin is like some sort of deglowing would have taken place. And in these injuries, suppose if you say that, okay, let me put some minimal invasive fixation like a plate, I will slide it in and put it, then often you may end up having a problem later on, because if it is a deglowed skin and if it necros, then immediately entire fixation that you did as a minimal invasive fixation would come off. So we have to exercise caution. So whenever you see a small skin wound or a deglowed skin, or if there is some laceration, but extensive bone comminution like this, always exercise caution. So you must not be too aggressive. So this is extremely violent injuries. So what we did in this patient is first put on external fixator as we do routinely. And then we debrided whatever the wound that was there. But one of the important points that you also must observe is that when there are two wounds, and then in between skin, there is some sort of abrasions like this or some sort of scratches like this. That means that skin is also a deglowed skin. If there are two wounds and then in between skin is, you must always take it as a deglowed skin. So what happens, you see, like after some days, it becomes dark, and then you can see it necrosis. And then you can see that completely we need to excise it off. Once you can excise it off, then immediately we need to think of a cover. But you see in these individuals, there is also like you all would have come out of a statement like zone of injury and zone of ischemia. In all the open injuries, though whatever that injury that we see directly is the zone of injury. But beyond that, there is also ischemic zone. That means there may be tissues that are nearly halfway damaged or 20% damage or some sort of minimal damage would have occurred. Similarly, the same thing would also happen to the vessels. Intimal damage would have taken place. So sometimes when you are trying to do a vascular repair and all, it may not work also. So you will have to be very careful. So all these put together. So here what we did was the LD flap. But you can see that after some time, it was showing some sort of necrosis, though it was viable. Underneath bones were becoming infective. So underneath bones were becoming infective. So purulent discharge was there. And then we, at this stage, we also suggested to him, because if any of these bones, if we go and remove it off, then it is going to end up having a long segment transport or something like that. So here onwards, we started warning the patient that this may end up having an amputation. So because if you don't tell anything and then you keep doing debridement and then end up having a long segment comminution, bone loss, and then you try to do a transport later, and then again you don't know what is the outcome. So you have to always give a question mark to these patients. Immediately you tell them that this can end up with amputation. But a lot of patients do insist to continue the treatment. That will happen to every one of you. So because Majority of the ladies are young girls who come to you. Often they will say that don't amputate, you want salvage. So a lot of patients would ask for it, but we need to tell them the cutoff point. So here again, what we said was, okay, we'll go ahead, but we did the redebridement and vacuum application. And once the vac is applied, and then you can see that it settles down. And this is a one we need to manage at this stage. So he has got a 25 centimeter of bone gap, whereas you can see that the other alignment, all the other bones are like that. So when we were debriding it, we didn't want to remove completely all the bones. Whatever the bones that were loose, we removed. Whatever there some soft tissue attachment was there, we still kept it in place. So because we kept all those things in place, so you can see that 25 still I didn't want to change any of it to any other type of fixation. We just changed few pins and then kept it there. And then these are the points that we needed to discuss, whether you can go ahead and do all these, whether bone transport, interlock nail, free fibula, graft, the revascularized fibula. These were the options that we discussed. On the contrary, we also discussed about infection, short distal segment, long duration, and then we have already done the free flap. So when already we have done a free flap, microvascular fibula again is very difficult to do because no other vessel would be available. So with unpredictable result, we were having a question mark in this patient, and then still we suggested an amputation, but patient would not. So what we did was, like, at a certain stage, we needed to change because the pin tracks were becoming loose. So we tried a few of the shank pins that were holding very well. We used the same shank pins and then put him on a plaster and then made him walk. And then later on, we converted into PTB cast, and it is after 9 months. You can see this how it is. And then still there is a non-union proximally. And then, but you see, he was okay with this. And then he continues to walk with caliper. And then at 20 months, he was becoming relatively pain-free, and he accepted it. And we also said that it is good enough to go ahead like this because we are pretty sure that it is continuing to improve, and then it will go on to have a good outcome. So this is the finally he was walking like this. So after that he has not come back. So he must be walking very well. We are in touch with the phone, and then he continues to say he's fine. So that is how we have managed that type of an injury. So what I want to tell is, not everybody will go through your textbook description of going into a same sort of like external fixator converted into internal fixator like that. So each of them will have a different management that you need to decide based on each of the patient's condition. And also, like here you can see it's a polytrauma scenario, and then this is how it was. So let us look at the open injury part of it. So he has got a small wound, whereas you can see the entire distal area, again, there is a lot of comminution. So here again, I don't want to be very aggressive because sometimes the skin will give you a lot of trouble. And then in this, we just try to do whatever the skin necrosis that happens, we try to manage it in the beginning. So you can see the total score was 11. So it was always a question of staged reconstruction. And then what we did was, once we put the external fixator, you can see the limb length alignment and axis rotation, everything was good enough. So when it is good enough, I didn't want to change anything. I was waiting for it to show. Meanwhile, the femur fracture was healing. And then we also try, once it was showing a good callus, when the time was come to mobilization, we removed these pins and then mobilized with the PTB cast. And then it goes on to have this type of healing. And then you can see that mild varus was there, but overall his function, everything was good enough, and he was able to carry home without any much problem. What I want to suggest in this is that do not be too in a hurry to change over to other methods of internal fixation in some of these fractures. So external fixator can still be not only be a temporary fixator, but sometimes it can also be a definitive fixator. But you must think, wherever there is a circumferential bone contact, limb length, rotation, and axis is maintained, still you have a chance that it can go on to heal. So you must show some patience in these type of massive injuries. So this is another 22-year-old male. So he has got a fracture, and then you can see he has got a type 3B segmental fracture, and then he has got various other injuries, but no systemic injuries as such. So it was only multiple limb injuries. So this is a segmental fracture, as I already pointed out. Whenever you have a segmental fracture, you must exercise caution. I have put all these examples only to tell where all you must exercise caution. So here you can see this outside it looks like there is a small wound. Whereas if you take it, obviously it doesn't look like major problem for as such. So sometimes you might also think, okay, let me put a nail and then cover it up. But you see, like at the end of it, after some time there was a necrosis, and then we had to remove the entire skin. And then you can see this is how it has been fixed. And then after some time we did the femur, and then you can see the total score becomes 11. And then the external fixator was maintained. And then we also went on to cover the go ahead to do the flap. And this is how it was, flap was done. But you see gradually over a period of time, what happens is the flap undergoes necrosis. The reason is flap undergoes necrosis not because of flap problem, but it will be problem underneath. So it becomes infected. And then you can see that when we open that, there is underneath, the bone doesn't show a good vascularity. So you can see once it is wiped, you can see it's completely pale. And when it is pale, there is no other option but to remove it off completely. So you can see that though we tried to do a cross leg flap thinking that it's only the skin, but it is not so, because it is the problem is in the bone. So it has to completely be taken out. So once it is taken out, then you can do the transport and then go on to do a transport and then complete it and get a good function. So what I want to say in this patient is that the same transport, you can also think of doing it in the very early stage, but you are always tempted to think that your bone would be viable because all the structures were intact. But in our experience, we found out that any segmental fractures, it is always you must exercise caution. Take long time to do a nailing. Take long time to do any of the internal fixations as far as segmental fractures are concerned. So these are the major lessons we have learned in segmental fractures. So this is how it is, and then finally he gets a good outcome. So the assessment of bone during debridement is the key step. Many of the times your bone transport will work wonder for you in open fractures. But only thing is when you are doing a long transport, make sure that there is no equinus deformity. Always have a foot assembly also in position, and then make sure it doesn't develop into any of the joint contractures. Asim, Negi sir, any questions at this stage, and then I will move on to the other cases.
I'm listening, sir. I have heard this lecture before, but every time you make it better and better. It's amazing.
Okay, sir. Now you can see that this
Excuse me, sir.
Yes.
Yes.
So when there is a wound and or later on there is a scar formation or a scab formation, say for example on foot or leg, then do you remove that scab and then do dressings, or you let it remain there and wait for it to shed off?
No, sir. If it is a very small scab, then you can wait for it to shed off. But if it is a bigger one, I think better to remove it and then nicely curate it and then do a skin grafting. It will heal faster. So that is a better way of dealing it.
So in post-op dressings of say open fractures or say closed fractures where nailing or plating has been done, how do you do? Do you roll it and press it to see if the blood is coming out and then do dressing, and which solution do you use or which ointment?
In a post-op situation, is it?
Yes, sir.
Yeah, post-op situation, if you think oozing is coming or not, you will always try to squeeze it from sideways and then see when oozing is coming. But we don't use any ointment or any solution to clean it. If it is a post-operative wound, you just use a spirit swab and then clean it and then do a gauze dressings.
And so what is your preferred solution to paint in pre-operative period in closed fractures and in open fractures?
Betadine only, sir. Povidone iodine
Okay.
only we use, sir.
Okay, so thank you.
Thank you.
Sir, every debridement in your hospital are carried out by plastic surgeon only?
Yes, sir. Only suppose if it is like if you want to put it in Gustilo's classification 1 and 2, it will come to orthopedic. So more than that, it always goes to the plastic department will debride it. So this patient, you all know that recently there was in Kerala, there was massive floods and things like that. So one of the lady was completely submerged and then got into it. So she was extricated after a very long time. So, and then when she came over here, this was the fracture. And then she had all these grade 3 tibia injuries and then multiple abrasions all over. See, like, because it took longer time with all this, so you can see this was the way it was. So many times you must know that when these patients are coming in, so the extrication time is also very important. If it was extrication time is very long, that means if something was log or some weight was on the body, so that means the crushing element is there for very long time. So that also will result in lot of rhabdomyolysis and things like that. So you'll have to be extremely careful. So in all these patients, you ask, suppose if there is any collision, vehicle collision, and then if there is all those instances where patients have taken very long time to extricate, either they are in hypoxemia or due to some weight, there may be some rhabdomyolysis. So all this you have to take into account in these patients. So here, this patient, you can see extensive damage, entire all over the body. And then when she came over here, then we debrided it and then we also did the flap quickly. But you see, like this patient developed a fungal infection. Many times when there is a fungal infection, what we think is that amputation is the solution. But what we did was like we removed that flap because you can't keep the flap again. Though it was viable, we needed to remove it off because if you keep covered it, we don't know how much of fungus is going to spread. So we continuously every day we keep cleaning this, and then once it is cleaned and then the good granulation tissue was happening. So we also use this. You can the plastic department uses this type of jet lavage and then keeps cleaning it every day. And then once it is cleaned and then good amount of granulation tissue comes up, and then we go ahead to do a resection and then transport. So that's what we did. So back, that is a fungal infection also got controlled, and then we transported it with the cross leg flap later. And then this was happening. You can see that we have done the transport, and then finally you can see that during this she was also pregnant at that time, so she also delivered the baby with the external fixator on. So, and you can see that now this is the time and they've gone back to normal activities now. So the learning points from that was that major crush injury can have delayed necrosis of muscle underneath. Bone stripped off from periosteum has poor survival. Fungal infection is not an indication for amputation. The preliminary, like split skin grafting or the negative suction pressure wound therapy is useful as far as the flaps are concerned. Cross leg flap is a great backup. Suppose if all those things are, if your flaps fails. Pregnancy can be maintained while with close monitoring. Positive mindset and full faith of patients in your team is very important. So this patient also was very important because the Kerala government was wanting that this patient must survive. So every time the government officials themselves will call. Every week they used to call. That is a great thing about that. So it was, I was very surprised that the government officials were calling every week. So without fail, they will call. So it was very nice of them to take care of the patient. So this is a 19-year-old girl. So you can see that there is a massive injury. Actually, she joined for the work recently. So, and then I think it was only 1 week at the work and then it happened. And so you can see this is the injury she has got. And then in this situation, like However bad the situation, in upper limbs, you need to think of salvaging the upper limb. For lower limbs, you have a good prosthesis. Suppose if you amputate also, there is excellent prosthesis available nowadays. They walk very well. So whereas for the upper limb, so far there is no good prosthesis. And also if the prosthesis, they want to have some sort of function, it is extremely costly also. So you'll have to take all those into account. So whatever you have to do in this patient to gain some amount of function. So you have to have a plan to start. So you have to think of a soft tissue and bone loss and functional tissue loss, everything you need to calculate. So if you have a full plan, then it is always possible. Suppose if you don't, then you need to get a help. So always get a good team to help you to sort out the plan. So like now you see, we just have to begin with our debridement, and then you have to sort out what are the things that are there. So we need to have a hand function finally. So you can see now we go ahead to debride, and then once it is debrided, the only bone available was that, so we need to fix. So we thought about one bone forearm. So one bone forearm is like you have ulna into the elbow and then radius into the wrist. So connect these two and then make it as a one bone forearm. And then once the one bone forearm is done, then some skeleton is come. And then you will have to think about getting the other job done. So this is the flap that you do. And then once the flap is done, then you will have to think, okay, what are the next areas we'll have to get the function. So here you can see there was some amount of deviation that was happening. And then we also thought about secondary nerve reconstruction and then the joint fusion, because as the deviation was happening. So these are the ways by which you thought about, and then we try to minimize the losses, and then see the thumb must meet the fingers, that is the whole function in the hand. And to that, we also got the way it has to be done. So all these are possible only with tendon reconstruction and then the nerve transfers. So once these are all done, then it becomes a good way to go back to the function. So even with one bone forearm, you can see that they all do very well, because with a little bit of extension of the elbow, with the shoulder rotations, they will all manage the way they need to pick up the things and then give it. So you need to be, you don't have to worry about thinking that one bone forearm is a great loss. Not like that. One bone forearm is a big boon as far as a good salvageability options are concerned. So we need to take that option and then keep going with the reconstruction of the upper limb. So you have to go to any extent to save the upper limb. So then only it will be good. So this around the elbow, you can see this open injury. So you can see that it's a completely shattered elbow, like a side swipe injury it was. When it is a side swipe injury, you can see the man, on the day one itself, we have gone ahead and then did everything that is required. So we did the primary flap. So Hari was there. He said he will go and do the flap also. We got ahead and fixed all this. So we try to get all the joint function, joint characteristic correctly aligned. So, and then for the humerus, I just put the two ender spin from either of the two columns, so that I don't have to do too much of fixations on there. And then once it is done, distally also, I just put the forearm and then got some sort of shape into it, and then the flap was done quickly. Always our Dr. Asabhavati, our plastic surgeon, keeps telling, DD, I will give you 20 minutes for any type of open injury. You must finish it in 20 minutes. So that with that aim and with that same speed, I want to finish me. This is the only option I had. So the fixation we did, and immediately they went ahead to do a flap. And you can see at the end of it, it goes on to heal well also. And then you can see all the fractures are healed with the same type of fixation. And then it also gives you a good function. So what I want to tell you is, like, if bones are viable, if you can get a good anatomy and then get a good early cover, you can get a good function. So this is another extensive injury. You can see the nature of this injury. And then the only option is, like, you have to think of getting humerus and then the radius, some junction we need to get it. We'll have to sort that out, and then that is the way it is. First we cover it, and then once it is covered, then we use a vascularized fibula, and then once it is vascularized fibula is given, so it is a straight arm. So with that straight arm, then she will also manage. Now that elbow is also not there, and then one bone forearm also it is. So a lot of people might ask, how does it function? Let's see, like the patients will get used to using those limbs. With shoulder actually gives you a good function. So whenever there is a problem, they will always use the extended arm, and then they will use it to pick up the things, and then they will try to give it, and then they will manage without any problem. So you will have to see. What I mean is, out of amputation, what you have done is the best. I don't say that it is good means I don't mean it is normal like opposite limb. If this is not done, what else? If amputation is done, how will they be? And what is this? What is it when you have this? That's what you need to take into account. And then you manage it like this, then they will all have a good function. They will be happy. They will be happy that you have saved their limb.
Even her appearance is great. She's looking beautiful. That will never be possible with an amputated upper limb.
Correct. See, like
she looks nice.
Yeah. So
normal.
Yeah, that is how patients also will be very happy. Recently, she came for flap thinning. So we have done the flap thinning also for this patient. So, don't know if salvage is possible, but put an effort to try to salvage it in all the upper limbs. Lower limbs, you can also think, you can always weigh the options of salvage and amputation. Whereas upper limb, you must always think as a salvage is the only possibility. If you don't know what they are in for, they accept salvage. Don't know what their life would be if the limb is not salvage. Again, the alternatives you must think. So it's always a responsibility for us to make sure that you always think of salvage in upper limb. So never ever think of an amputation in upper limb. So I always want to end this talk by telling about the mangled limb, because some of the confusions are there about telling about the mangled limb. What is a mangled limb? So the definition is that any extremity with at least 3 out of 4 tissue groups are affected, like integument and soft tissue as one, nerve, vessels, and bone. If you take all the 4 as a separate tissue groups, if at least 3 are gone, that means it is a mangled limb. That is the definition given by this Gregory et al. So they have given this definition, so that is valid now. So when there is, these are the questions you have to answer. Suppose if it is, if you want to address it as a Gustello-Anderson's classification. So is all the grade 3 can be termed as a mangled extremity. What is the expected resource of outcomes? So what is the patient factors for the success of treatment? And then the utility of scoring systems and outcome after salvage and amputation. So the mangled limb, always the question is salvage versus amputation. So I already gone through a lot of issues about salvage versus amputation. So I would not go ahead again. But you see, like if you take Gustello classification, if you take 3A, 0% is amputation in the literature, whereas 3B and 3C, if you take 16% and 42% end up having an amputation. So by far, Gustello 3B and 3C can be termed as your mangled limbs. So what is the expected resources for outcome? Limb salvage requires greater resource of investment. That means each of the hospital, each of the health concerns, they will have to do a lot of resource investment. So this have been published. So you must not say that, oh no, this can be done only here, that can be. But every healthcare provider, irrespective of the place, they can do all the open injury management. What they need is, for any debridement, you need to have a good loop for magnification. Otherwise, there is nothing else you need. All other is available like management of any other practice. So you have to have it. Only thing is the resource investment comes only need for your colleagues to be together. So if you look at the recently published standards for the management of open fractures, they have said that hospitals that have established orthoplastic services have demonstrated reductions in deep infections and then lot of savings, and then outcomes are also better. As well as they have reduced infection rates. Improved outcome include lower rates of non-union and amputation. Fewer unnecessary trips to theatre, both for planning and then treatment and revision surgery. Shorter hospital stay, early recovery of function. So all these good outcomes and then good management comes only out of combination. It's an orthoplastic approach. So the orthoplastic approach was first devised by Marco Godina. Marco Godina, he is from Ljubice, somewhere in Serbia. So he devised this term, and then whoever has followed this orthoplastic approach, they have made it better in open injuries. The patient factors are like, suppose if there is a older age, lack of education, poverty, and smoking, all of them have given a poor outcome. So this is from the LEAP study. So LEAP study is another big group. So they have done a lot of work on open injuries. And whatever the articles get quoted is from the LEAP study. So you will have to see that they have mentioned that the older age, lack of education, poverty, and smoking is cause of a poor results. And also, if what is the usage of the scoring system, they are only adjuncts to your clinical judgment. It is not like, okay, you apply the score, it will be same thing. Not like that. They will all be your adjunct to your management, your judgment, whatever clinical judgment you are going to make, they can add to your clinical judgment, but they are not going to tell you what is this, what is that. So it has to be, you have to apply those based on your clinical judgment. So Ganga Hospital score that we have done, it is based on large experience, and then it is for that purpose alone, we said that it helps you in actually getting your utility of management and then salvageability. Everything you can answer it if you apply that score. And it's also available in both Android as well as the app systems. So what we have said is the salvage recommendation: below 14 you salvage, above 17 you amputate. So all these scores, you must put it in the right perspective. They tell you whether it's salvageable or amputation, but you can also extend the salvages. You can also, like some of them, you might think it is amputation, but you can also try to salvage and see if your skill levels are better. So it is not that they are the that you must follow. But salvage depends upon the attitude, skill levels of the team, and then the infrastructure in which the team works. What is important is the early good resuscitation. It has been proved beyond doubt that if you have done a very good early resuscitation, infection rates are less. So that has been proved beyond doubt. So you have to make sure the resuscitation is the key. So as I said, Ganga Hospital protocol is that all severe injuries are received in the anteroom of the operation theatre, where intensivist receives the patient, and he is the one who is going to resuscitate and make him better for us to go and operate. So all these primary management is important, and once it is managed, so we also developed what is called the on-arrival block. So once the patient comes in, we give the block to the patients. Whether it is upper limb, they go in for an upper limb block. If it is a lower limb, they get a femoral nerve block and then lower limb block, so that immediately patient is not growling, not shouting, so he becomes calm. And then you can call in the patient in the anteroom of the theatre. You call in the patient attenders and show them the wound. You twist the leg and show them the wound. Immediately they will all get frightened, and then they will be so they are all so afraid to see it also. But take a picture and then show them again next day, and then they will all then become quiet. They will all cooperate with you with all the management that you are going to do. So this is one of the important areas that you also need to look at. So on arrival block, make the patient calm, show the patient all the wounds, characteristics, everything. You can show them and then explain to them. And as the patient is calm, they will also get enthused about that patient is happy, patient is quiet, so pain-free and all. It will be a calm scenario at that area. Whereas when it is in a casualty, 10 people will come with the patient, everybody will be shouting, everybody will be making some or the other issues. So best is to bring them, make them calm, and then show the wound, everything, they will be happy about it. A well-resuscitated patient is ready for staged reconstruction much earlier and tolerates the procedures well. Helps to keep the patient period of hypotension, hypoxia, and hypothermia very short. The decision making is extremely important. So senior output, senior input. See, like, so this is one of the patient I always try to keep telling, because see, like, this patient arrives on Sunday afternoon. So our senior consultant was Hari Venkatramani for the plastic department. My colleague Ramesh was there on that day. And then they had received this patient when the hemoglobin was very low. Our anesthetist said, whatever it is, we have to do it. So they started with the resuscitation on one side. And the same time, we also went ahead to do the debridement. And then you see that at the end of the debridement, this is what is available for us. So a below knee on one side and the above knee on the other side. And then entire other areas are all crushed. So our team members decided to do the cross leg replant. So what they did was the opposite leg below knee has been connected to the above knee on this side. And then you can see the rehab in progress. And then now she's a happy child. And at 1 year follow-up, she's like this. And then now she has gone back to classes, and then she has started getting prizes, because automatically teachers also like this, and then they will also encourage. And then now she is very happy child. Recently, now the parents have come forward to get her to Para Olympics, and then they are trying to give her the shooting competition skills and things like that. They are training her for that. So hopefully tomorrow she wins some Olympic medal for. It will be very nice. So, and then it is a complete plan that you need to make. You have to make a complete plan for this patient. When it is a mangled limb like this, and then you have to, when the bones are exposed, then you need to completely resect. So when it is a very thin segment distally, and then you have to make sure that there is no equinus contracted, that does make a foot assembly, and then go on to do a transport. You can see the transport is completed, and then he is back to normal activities. So all these early treatment are extremely important. This already have put it, so we have gone on to show this again. So here again, so one more similar fractures. Then you can see that this goes on to have a primary orthofix. So as I said, we don't try to put external fixator in the beginning and then go on to change. So this can also be used as an external fixator. LRS itself is an external fixator. Initially itself, you mount it in a good position. We have come out with what is called the spacer rod technique. So because the open injuries, you can see it. Intramedularily, a small strut can be given, like a metal strut, and then on top put a plate and hold it in position. They will be in good alignment, and then you can get the LRS frame quickly done and remove of all those intramedullary strut as well as the extramedullary plate that you have put. And now it is in good alignment. And once it is in alignment, you cover it quickly and then transport it, and you will get a good docking. So once it is docked, then here what we chose was, because this girl wanted to go, she was like working in one of the airlines, so she wanted to get back quickly. And then what we did was to put a long plate so that the regenerate site as well as the docking site is completely fixed, and then she has again gone back to normal activities. So these are all the happy families that very good outcome that you get. But there are many patients like this. I just put only 4. But on the contrary, you also must remember, with the volume that we do, we also have a lot of amputations. We have a lot of secondary amputations. And then those instances are also there. But what we can vouch and say that is, with the plastic team that is very eager to do on day 1 reconstructions also, we are able to get a much more better outcome than what we essentially think it is possible. So this is a collaboration from the Michigan hospital, and then those guys came here, and then they also saw our hospital pictures, and then they took out the papers from us, and then they said that even earlier and all, when there's a posterior tibial nerve injury means, they used to say amputation. But nowadays the dictum is that it's not necessary. You have to go and salvage those limbs also, and then it's also they have written it up. And then the outcome after salvage and amputation is patients suffer significant disability after mangled extremity, regardless of the treatment type. Some of these guys they don't go back to normal activity. Some of them have got some or the other problems. Some of them do come back with, say, stiffness, swelling, and then they continue to complain of some problem or the other. But thing is, overall open injury management, it is only possible if you are passionate about it. If you are not passionate about doing the open injury management, it is very difficult to do it because they all come at night times. They all come at very late. And then if you have no energy or no enthusiasm in doing that, then it is not possible. The enthusiasm and energy only will come when you have a good teamwork to play with. If you're a plastic surgeon and you become a very good team player, then you will definitely cherish the moments of this journey. In this journey, the favorite moments comes with major injuries. So you will always cherish that when they are walking very well, and they're always indebted to you throughout their life. So you will find that it is extremely good. So the attitude and the skill is very important. So it is a combination that works. Anesthetists are the lead. Plastic surgeons come first. We go and fix it, and then we make as a team. But unfortunately, if there is any problem that happens, it is only the orthopedic surgeons who takes the blame. So that's why you must own the patient. You must always own the patient, and then discuss continuously with anesthetists and then the plastic surgeons to get the going correctly. So you must not delay some of the stages. So you must continuously involve all of them and then get suppose first day everybody is together, next day if there is something, then they may not be coming together, then all those things you must sort it out. So that is why you must always remember, though anesthetist receives it, plastic surgeons debrides it, you own the patient, because any problems, it is orthopedic surgeons have to take the blame. So you have to make sure everything goes right. So the combination has to go very well. And then if it is there, then it all will work well. But at the end, I want to tell you these things, because the confidence in reconstruction comes only when you have a courage. Okay, when you have the courage in during the debridement. It is opposite. See, like, how will you debride very well? Say, I kept on saying that you at the end of the debridement, you must leave only the viable tissues. How will you leave the viable tissues? Only you do the radical debridement. When will you do the radical debridement? Only when you know that you can, whatever the defect you get, you can reconstruct it. That is when you have that capacity, then you will always debride it very well. So I think that is the key. So confidence in reconstruction comes out of your courage in debridement. That is because of your all the skills that put together in the team. So what has made the difference? A senior consultant in each specialty is always on call. A senior anesthesiologist always receives the patient and we do the rest. So the orthoplastic approach, decision making, technical skills and outcomes must be as that of a closed fracture. See, like, if you get all this quickly done, then your open injuries also will heal in the exactly same time frame as your closed fractures. So you must own the patient in a team. So this is how you manage your open injuries. Any questions I can take?
Sir, Dina sir.
Yes, sir.
Most of the patients in our setups, they come late.
Yes.
So how late is late for not choosing a nail? We are not talking about frankly pouring pus type of situation. Patient is on the table, say around 48 hours, grade 2 to grade 3A compound fracture. So do you, and is nailable. Otherwise, suppose that patient would have been there in first 24 hours, there is no debate that we can nail it. So how do you decide for those patients?
So late arrivals also, you must think like if it is, I think what determines would be your contamination level.
Yeah.
If the contamination level was higher, I think it is always better to go in only with external fixators. If the contamination was not there, even if they come 24 hours late also, you can still go ahead and do it like what you have done it in the primary set. So your contamination and soft tissue damage, these are the two issues when the delayed presentations will make the difference.
In some of other lectures, you have shown acute shortening.
Yes, sir.
For getting quicker union, and then you lengthen at a...
Correct, correct. Yeah.
So how much of the acute shortening you have done?
Sir, in femur, we have done up to 7 centimeters of acute shortening. In tibia, we have done up to 5 centimeters of acute shortening. So forearm and humerus, again around 4 centimeters, we have done a shortening. But femur, though many times, because of the soft tissue bulk, a lot of people will say that it won't allow collapse. But we have the maximum that we have done was for the 7 centimeters. See, in those instances, actually, the soft tissue damage was also very high.
Yeah. So,
whereas if it is, yeah, when the envelope is completely there, you cannot shorten it. So tibia, I think 5 centimeters. Natarajan was one patient, 5 centimeters shortening we have done. So
there are 2 or 3 papers where they have talked about local use of vancomycin and gentamicin to reduce the infection rate. So you agree with that observation? Toulé's paper is there, and some now there is one paper in 2019, another in 2017-15. So what is your take on that? Sprinkling using local vancomycin and gentamicin.
So we have not used it, sir, but in the spine department we use.
Yeah, they are using. I heard Shetty. Yeah.
Yes, sir. The spine department they use, but we don't use it, sir.
So how come it has not percolated? You must be observing their experience.
The only reason I can tell is like open injuries by far. The tissue damage and all those things are different compared to a surgical dissection and then the soft tissue management. So I think that is the way I look at it, but somehow it didn't impress us to take it to open injuries. But we do use stimulant we use, sometimes we use bone cement, antibiotic bone cement as a dead space fillers. But we don't use vancomycin sprinkling and things.
You showed large number of cases in a very great talk. So we didn't see many bone grafts. So how often you go for elective bone grafting? There were lots of segment transports, but
no, I chose in this talk, I thought because it is like a fellowship training, I wanted to give only the aspects that are related to where you must exercise caution, where you must definitely salvage, where you must think of an amp. Like that, I placed this talk, but I have a lot of patients for bone grafting and things like that. Actually, in TraumaCon this time, my talk was on bone graft.
I heard that. Yeah. I was there.
So like that. So
I will request you to explain your antibiotic regime for a grade 3 compound again, because it's extremely difficult to convince people that you give it for such a short time, give a break, and then again give it only for 24 hours. So just elaborate on that. Suppose there is a grade 3B or C fracture. So how many days they receive?
So grade 3B injury, say for example, today I'm operating. So moment they come in the casualty, they get a first shot of antibiotic. The cephalosporin, that is a super cep, they get 750 milligrams. And then they come to debridement stage. From the casualty, they come to day. Suppose if the 8 hours has elapsed, they will get one more dosage in that theater also. So if they have not, if the 8 hours has not elapsed, then that is still that if the soft tissue cover is also done in the same time, then only 3 doses are given. Suppose if the soft tissue cover was not done, then it will continue to the second day. After that, we stop. We don't give it beyond the 2 days time. Suppose the next soft tissue cover comes, say for example, on the 3rd day or 4th day, then again 1 shot of supercep would be given as a like any other surgery that is being done. elective surgery is being done. After that, we stop. We don't continue it, sir.
I wanted it to come from you.
We don't continue it. Say we have a good HIC team here, that is Hospital Infection Control Team. So we have made nurses to be the chief in charge. So what they do is we need to give an explanation as to why we need to continue the antibiotics. Suppose if we make doctors as in charge, then it is sometimes our colleagues will go and speak to them, and then they will have some way to get it sorted out. But when the nurses are made in charge and then they are controlling it, it is little difficult to, because they are continuously monitoring. So,
if there is a patient who has got a general surgery issue also, the general surgeons have done some laparotomy, and there is a maxillofacial surgeon who has done something here. So they are extremely fond of giving IV antibiotic for 4 days and 5 days. So how the issue is resolved then? Orthopedic literature is very clear, but it's not that clear in their science, general surgeons and the maxillofacial. So how
so this issue do creep in, but when these issues do creep in, we give way, sir. We allow them to give their antibiotics.
Thank you, sir.
Thank you, sir.
Extremely obliged. It was great learning experience. Unbelievable.
Thank you.
Really thankful, I'm sure. Yeah.
Thank you, sir. Thank you very much, sir. Good night.
Thanks a lot for sparing so much time and energy.
Thank you, sir. Thank you very much.
It was really pleasure listening to you.
Hello.
Yes, sir.
Any questions to Didi, sir?
Yes, sir. So my question is, in all your case, I see you are putting fixator on the lateral side.
Yes.
What we used to we learn is we are usually putting fixator on either medial or anteromedial side. So is there any precaution we need to take while putting fixator from lateral side, as there is anterior tibial artery and neurovascular bundle is there?
Yes, sir. Distal third, you must definitely be worried about it. The only way is you must use a sleeve. You must nicely dissect and then use the artery clip to nicely separate it and make sure that when the sleeve goes in, and then when you are using a shants or whatever the drill bit, it must not wind around the soft tissues.
Sir, another thing is, in your setup, your placement of the fixator is guided by what your plastic surgeon colleague has planned for the patient.
Wound dictates.
Wound decides where you put it.
Correct.
Orthopod deciding.
Wound dictates where you have to put the external fixator.
What he wants to do to cover it.
Yes.
He suggests.
Majority of the times in tibia, you will see that the wounds are all almost on the medial side where it is opened out. Either the cross leg flap would be all right, or sometimes when they are putting a free flap, they are all coming more often on the medial side and then covering it. So it is easier to have a fixator on lateral side. You don't have to change it.
Yeah.
Sir, any comment on muscular technique you are using or not?
Muscular technique we do use, but we don't use it often. So because we have a good plastic department for microvascular pre-fibula, microvascular fibular grafts, we don't use muscular very often. But in open fractures, especially in the distal femur, sometimes when the bone gap is there, we have tried to use it as a, I don't truly call it as a mascule, but still, if you want to put it as a mascule, we can use it as now, but not many cases, sir. I don't have much experience to share it with you.
Thanks a lot, sir.
Thank you.
Yeah.
Thank you, sir. Good night.
Yeah, we call it a day.
Yes, sir. Yes.
Thank you. Good night, sir.
Good night.
मेरा एक चौथा भी